Hello there, my name is Ling. I'm one of the junior doctors for Nottingham University Hospitals, and I'm one of the team members behind the creation of this series of concept maps. So welcome to this week's teaching. Today we will be briefly covering the multiple presentations of stroke and correlating it with which areas of the central nervous system are affected. I'd like to note or bear in mind that this teaching will not cover the management of stroke, but rather sort of the identification of it. So then, a brief introduction on stroke, or as we call it, cerebrovascular accident. It generally refers to a rapidly developing syndrome or cluster of focal global neurological deficits which are lasting and with evidence of tissue transformation on neuroimaging. So as for TIAs or transient ischemic attacks, also known as mini strokes, there is now a shift towards a tissue-based definition where there are transient episodes of neurological dysfunction caused by ischemia without evidence of acute infarction on neuroimaging. However, it was previously defined by the onset of such symptoms as lasting less than 24 hours, but now the time limit to it has been removed. So, strokes are generally classed as either ischemic or hemorrhagic, with the former, with ischemic being more common. So we will then cover the difference between these two strokes in the next slide. So in this slide then we'll briefly cover the different features, as I've said before, that makes either ischemic or hemorrhagic strokes more likely. The definitive investigation is still an initial CT head to exclude any hemorrhagic transformation, because management for these two types of strokes are very different. However, it is still useful to have an initial idea of what stroke it could be in a newly presenting patient. So in assessing risk factors in your history taking, a simple past medical history, social history, and drug history will be able to shed more light on what strokes will be more likely in your patient. So risk factors for ischemic strokes would be ischemic heart disease, previous MI, diabetes, smoking, AF, whilst a patient on the background of uncontrolled hypertension or on anticoagulants should raise your suspicion on whether this could be a hemorrhagic stroke. Speaking about onset during sleep when your circulation is least active would make ischemic strokes more likely, and conversely an onset during activity or exertion when your circulation is more active would make hemorrhagic strokes more likely. However, with that said, this is not a clear cardinal rule, and you can certainly see both types of strokes in both types of onset. So it's basically just which one is more likely than the other. So in your next slide, we use the Oxford Stroke Classification. It's also known as the Bamford Classification. This classifies strokes based on the initial presenting symptoms, and using this classification, you initially assess for the following three criteria, which is unilateral hemiparesis or hemisensory loss, homonymous hemianopia, and higher cortical deficit. So you'll have your infarcts in your anterior circulation, so you can have total anterior circulation stroke, partial anterior circulation strokes, and then you can have your strokes or your infarct in your posterior circulation, and you can have infarcts of strokes in your lacuna region. So with total anterior circulation strokes, it basically involves all three of the following criteria that I've mentioned, and it is essentially an occlusion in your anterior and middle cerebral arteries. However, in partial anterior circulation, where you only need two of the above criteria or an isolated higher cortical deficit, it involves the smaller arteries of your anterior circulation, such as either your upper and lower division of your middle cerebral artery. So with posterior circulation strokes, I've sort of highlighted it with an asterisk because I will present slightly differently. It usually involves your vertebro-basilar, your cerebellar, and your posterior cerebral artery. So your patients can present with any one of the following. Can present with isolated homonymous hemianopia, cerebellar dysfunction, ipsilateral cranial nerve palsy with contralateral motosensory deficit, or bilateral motosensory deficit. And with your Lacuna strokes, it is basically an infarct in the deep penetrating arteries in your internal capsule, thalamus, and basal ganglia. So patients with Lacuna strokes will present with only one of the following. They can either present with pure motor stroke, pure sensory stroke, and ataxic hemiparesis. So I've also highlighted higher cortical deficit with an asterisk because we will cover it in the next slide. So in this next slide, I'll be covering the common higher cortical function deficits. Please note that this is not an exhaustive list, but rather a mention of common cortical function deficits. And deficits like this arise from lesions within the cortex, as I've implied. So your common cortical function deficits would be your aphasias. So you have receptive aphasia, dysphagia, which is your Wernicke's, and it is essentially affecting your temporal lobe. So your patients will lose the ability to understand language and they will have impaired comprehension. With expressive dysphagia, which is a lesion in your frontal lobe, your patient would lose the ability to produce fluent speech, to produce language, express themselves, and you will see impaired speech in patients with expressive dysphagia. And with neglect, it is a lesion in your parietal lobe, and it's most likely your non-dominant parietal lobe. It is essentially a lack of awareness and a failure to report, respond, or orient to meaningful stimuli presented on the affected side. And with your apraxias, it is also a lesion in your parietal lobe. It is a loss of ability to execute, learn purposeful movements. So for example, your patient can have a stroke and be unable to tie their shoelaces after that. It's essentially a type of apraxias. And then you may have your anosognosia, which is a persistent denial of the existence of having a stroke actually. So as per the Oxford Stroke Classification, begin your assessment by initially looking for the 3 criteria. I will usually start with determining is there a high cortical dysfunction first. So if there's no high cortical deficit, it makes lacuna, infarcts, and posterior circulation strokes more likely. And if there is high cortical dysfunction, you can sort of narrow it down to an anterior circulation stroke. Then, with higher cortical deficits present, you can ascertain whether the other 2 criteria is present as well. Is the hemiparesis and homonymous hemianopia. So presence of all 3 signs would point towards a total anterior circulation infarct, whereas presence of only 2 signs will point towards a partial anterior circulation infarct. And sometimes you may only see cortical deficit, isolated cortical deficit as the only sign in a partial anterior circulation stroke. So once you've narrowed down the likelihood of your patient's presentation is secondary to either lacuna or posterior circulation strokes, it is then time to look out for the associated symptoms. I would initially look out for the following 3 presentation. Is there homonymous hemianopia? If it's an isolated case of homonymous hemianopia, it is quite likely to be a posterior circulation stroke. Is there hemiparesis and is there hemisensory loss? So if the patient has hemiparesis and hemisensory loss, the next thing to determine is whether there's cranial nerve involvement and is there any cerebellar sign. If it's an isolated hemiparesis / pure motor stroke, it is quite likely to be a lacuna infarct, and similarly in an isolated hemisensory or pure sensory stroke, it is also likely to be a lacuna infarct. Now, in the presence of cranial nerve involvement, it is worth noting that with brainstem strokes, you will present with ipsilateral cranial nerve palsies with contralateral motosensory loss. So bear in mind that the lesion in the brainstem will be ipsilateral to the side of the cranial nerve that's affected. So then, in third cranial nerve palsies with contralateral hemiparesis should raise your suspicion on Weber syndrome. So it is essentially an occlusion in one of the branches of the posterior cerebral artery, resulting in a midbrain infarct within the brainstem. And 6 to 7 cranial nerve palsy with contralateral hemiplegia is likely to be Millard-Gabler syndrome. It is a ventral pontine syndrome in the brainstem as well. And with your patients with cerebellar signs, if the patient has an isolated ataxia with hemiparesis, it is likely to be a lacuna infarct, as I've mentioned before. So strokes that present with a constellation of cerebellar signs, such as ataxia, nystagmus, vertigo, coupled with Horner's syndrome, should really start getting you thinking about lateral medullary syndrome. It's otherwise known as Wallenberg's. So it causes a range of symptoms due to ischemia in the lateral medulla oblongata and the brainstem, and it rises from an occlusion in the posterior inferior cerebellar artery. It also presents with other symptoms such as dysphasia and paresthesia in your face as well. So next slide. So that's sort of the end of our brief sort of guide of our concept maps on sort of navigating through what types of strokes your patient may present with. And some of the key points that we can go home with is it's good to sort of differentiate or have an idea of ischemic versus hemorrhagic strokes. It's good to know the Oxford stroke classification as well. So it's good to know that your stroke, is it likely to be arising from an anterior circulation infarct, posterior circulation infarct, or a lacuna infarct. A thorough and full neurological exam would be essential to determine the constellation of signs and symptoms that your patients present with. And some of the few key things that you want to ascertain when your patients come in with stroke is there hemiparesis? Is there cortical deficit? Is there homonymous hemianopia? And are there any cranial nerve and cerebellar involvement? I would consider all these 5 things to be sort of the main things that I want to find out when I have a newly presenting patient that I suspect has stroke. So then some extra reading, you can go and read about the Moto Homunculus or the sensory homunculus. So basically this picture sort of shows you the motor cortex and the sensory cortex in the brain. So this is a map of brain areas that in your respective motor cortex is responsible for motor processing of different anatomical divisions of the human body. So this will be useful if you want to localize the lesion within the motor cortex by correlating it to which parts of the body are more affected than the others. A little bit of extra reading as well. So this is a table that will correlate your higher cortical deficits or abnormalities to which lobe is affected. It's quite a huge table. It's quite a huge list. Well, I certainly don't expect you to memorize all of it, but it'll be good to know the main higher cortical deficits that patients commonly present with, as I've mentioned before, like aphasia, both your receptive and expressive aphasia, your neglects, and your praxias. And lastly, this is basically a slide from Calgary Guide on sort of localizing where your ischemic stroke has taken place by the impairment that they present with. And lastly, just a general guide, remember that, we don't expect you to memorize these concept maps, but we just expect these concept maps to sort of guide you to form your own thought processes and sort of help you in your clinical reasoning. Start thinking about what you would do if a stroke patient presents to you. In any presenting complaint, we would identify and rule out life-threatening causes first. That will be the priority. Feel free to pause these videos at different stages of the concept map to see it in detail. And I hope you enjoyed this presentation. I hope that it was useful and it has helped your understanding of stroke. Thank you very much.